Once you come, we'll start, is it?
Yeah.
Okay. चालू होने के बाद बात नहीं करो.
Good evening, everyone. We welcome you all to OrthoTV Monday Motivation Webinar Series. And today we have a full house and we have a lot of spine surgeons as panelists and also the spine surgeon as the speaker. So just to name the panelists, we have Dr. Abhay Nene, Dr. Raghuprasad Varma, Dr. Priyank Patel, Dr. Satyen Mehta, Dr. Premik Nagad, Dr. Tushar Agrawal as our panelists. And to introduce today's topic and speaker, I hand over to our Dr. Abhay Nene. Over to you, sir.
It is such a proud privilege to be presenting to you Dr. Shekhar Bhojraj. Clearly a larger-than-life persona, Dr. Shekhar Bhojraj is widely credited to be India's first spine surgeon, the person who led the movement of a subspecialty of spine surgery and started the first neurospinal unit way back more than 30 years ago. He's been a visionary, a motivator. He's been an academic guru. He wears multiple caps. He's the guy who walks the talk of work-life balance. He's been a mentor and a top-class spine surgeon. But amongst all the hats that he wears, we're going to be presenting the hat today under which there is a kind, caring soul who's given back to society in a way nobody else has by creating what is now popularly known as a Spine Foundation. An NGO of sorts, which gives back to the public in the category of spine surgery. And Dr. Bhojraj has immersed himself into this as his life's project to give back to the poor and the needy the care of good spine from a good spine surgeon. And this has been his pet project. And today he's going to talk to us about the journey of the Spine Foundation. And it's once again going to be a really motivational Monday for the last Monday of this year. It's going to be memorable indeed. May I present to you the great Dr. Shekhar Bhojraj. Over to you, sir.
Hi, everyone. Hi, Abhay. Thanks for the introduction. And I would like to thank the organizers for giving me this opportunity to talk to you about something which is very close to the entire spine unit and the Spine Foundation. So I'm going to talk about the excitement of social and community medicine for a spine surgeon. And I'm going to talk to you all about the journey, so to say, beyond spine surgery. What is it all about? It's about setting up a comprehensive spine care program for the unreached and the underserved populations of rural and urban India. The Spine Foundation experience over the last 2 decades, starting from 98 and now 2020. There's a population explosion, as we know. India is the second most populated country in the world, and it has nearly 1/5 of world's population. And there is always a fight for survival. It's very important to know that the rural population of our country is more than 70%. And India has almost 642,000 villages with urban population less than 25 to 30%. And India is short of 5 lakh doctors. The doctor-patient ratio is worse than that of Vietnam. As you all know, it's a land of contrasts. And in cities, we have migration from villages to cities, as you can see. Now, what are the problems which are specific to the developing countries in the Asia-Pacific region? I think they are twofold. One is lack of affordable private insurance and self-paid healthcare. And hence, the big factor of unaffordability. The current healthcare of India is dominated by the private sector. And although the government health systems, the public healthcare systems are free, but they are grossly substandard. And majority of Indian citizens do not have health insurance and they have to pay by out-of-pocket expenses. The unmet and unreached healthcare, as you can see here, primary healthcare is supposed to be provided free by the government and the rural primary health services, but only if they are functional and reachable. Specialized secondary and tertiary care as required for advanced treatment such as spine is only available in major hospitals in bigger metros and cities, which is far beyond, way beyond the reach of villages. This is a very important concept I would like to tell you. It's called the CHE, or the catastrophic health expenditure, which is defined as the health expenditure that threatens a household's capacity to maintain a basic standard of living. And there's a study which shows that more than 35-40% of the poor Indian households incur this CHE. The rural areas have problems, shortage of medical professionals. More than 70% of doctors are in the urban areas, whereas the population is 70% and more in the villages. And the lack of human resources in villages forces the rural population to resort to fraudulent and ignorant healthcare providers. Although there are 1.4 million doctors in India, the doctors do not tend to work in the rural areas for obvious reasons, and private doctors tend to be specialized in a specific field. So they reside in urban areas where there is a higher market and financial ability for those services they have learned. So we spend 80% of our time as surgeons and effort in servicing only 20% of the population at the top of the pyramid and neglecting the 80% at the bottom. We spend a lot of our time and training in perfecting surgeries and treatment options which are specially catered for this top of the pyramid, such as cosmetic surgery, endoscopic surgery, replacement, and instrumented fusions. Marketing of expensive imported products is aimed for the top of the pyramid, which has no relevance to the majority of the population. Why work on spine problems? Is that a real need or just because we are spine surgeons? In an interesting study, almost 4 to 5 years ago in the Lancet, emphasized this problem about the global burden of disease, and back pain and spine related problems topped the list. It was ranked as one of the most important factors which produce disability, and it's only going to increase. The another factor which is very important is the role of surgery in primary healthcare issues. 11% of global disease burden is treatable by surgery, and yet more than a quarter of the world's population lacks surgical procedures. This is an interesting book which I came across in Boston, and this book is on Operation Health, and this book makes a compelling justification for adding surgical care to the global health agenda. Is the need real in India? Just to give an example, this girl, 8-year-old girl, had a fall in a place 460 kilometers from Mumbai and had no access to spine surgery, and she was finally brought after a long time with all these bed sores with a spinal injury. And you can see the health minister at that time first noticing that the healthcare was missing in the periphery. So the Spine Foundation is completely a need-based initiative. And I'm going to share with you the journey over the last 20 years. Basically, it is focused for the service of the have-nots. The spine unit, since its inception in 98, has specialized in management protocols which are specially geared for the have-nots. What is it that we really want to do? We at the Spine Foundation want to initiate spine surgery setups in areas where affordable and rationalized spine care is not available to the unreached and underprivileged. Taking care of the surgical expenses, including investigations, hospital stay, medications, implant costs, rehabilitation. It is mainly relied on donations from the rich patients, philanthropists, and cross-subsidy concept, as popularly called as the Robin Hood concept. The vision is to set up 4 geographical zonal centers in India, North, East, South, and West in India, which provide spine care in the respective zones. And it is done along with close coordination and cooperation by the ASSI, the Association of Spine Surgeons of India collaboration, where the Spine Foundation heads the social wing, and also where it's part of the RC, which is the Association of Rural Surgeons of India. How do we do it? It's not a one-man show. It's neither effort of a couple of people. It's a huge team effort. So combined decision plans are made. Delegation of duties and decentralization is the key. Now, what's the typical working module? It starts with evaluation camps, local surgeon identification, assessing the needs of that area, identifying local setups, setting up systems and teams to take care of these cases pre, peri, and post-operatively. But the final success of these ventures lies in turning the turnkey projects into permanent self-sustainable spine service centers on an ongoing basis. Empowering the local village health workers to manage the show, identifying local doctors interested in helping and assisting, and finally the financial self-sustainability models using available government schemes and local health schemes. Networking links with secondary and tertiary care centers is the key. And nowadays, using telemedicine and advanced applications for patient evaluation, diagnosis, post-op follow-ups, and long-term monitoring. Involving local medical colleges and institutes, and involving the infrastructure manpower at the local areas. The typical working module consists of adopting economical options in spine surgery, but mind you, without compromising whatsoever on the quality. The spine unit over the years has very proudly practiced, popularized, and propagated and published the following 4 principles: conservatism, simple surgical techniques, low cost affordable implants, and easy to learn reproducible methods. Economical options in spine surgery is no surgery at all, surgery without implants, and surgery with simple low-tech indigenous implants. That is later on. Excellent clinical outcomes at long-term follow-up. Just a few examples. This patient had a fracture and advised complex surgery. It was conserved with a brace, long-term follow-up. TB spine advised a major surgery, which was conserved. You can see at long-term follow-up, excellent result, both radiological and imaging-wise. Another patient advised complex surgery, treated conservatively. So conservatism is a role, and this was published in international literature. Coming to surgical techniques, following simple techniques, this patient was advised a major complex anterior surgery with implants, but got away by doing a simple 45-minute posterior surgery with an excellent end result. These results were published in international literature, as you can see here, with a classification to guide. Problems specific to developing countries are complex neglected deformities. The dilemma of a young spine surgeon in India is the pressures of delivering the correct treatment to the unaffording patient with minimum cost but with maximum benefit. Our priorities are different and needs are different, and our approach has to be different. So we are looking at self-reliant methods with self-respect and simplicity. This is just a comparison of the original imported implant, a copy with an Indian make, and a locally made design. So in solutions, we have simple time-tested devices and easily reproducible implant designs. Just to give an example, this is a very complex cervical spine deformity, which we corrected using a simple small piece of wire just by following good principles. This was published in the American Spine Journal way back almost 25 years ago. Another Indian implant locally made for a complex deformity with a front and back surgery in TB spine. Tumors dealt with locally made Steffi implants, absolutely cheap. Another very complex giant cell tumor patient operated with a simple heart shield with all following all the principles such as embolization, cementing, and anterior reconstruction. This was a in vitro implant made like with a bone cement and a Sherman plate. This patient, we now almost have a 32-year-old follow-up. Another complex deformity, a young girl from Akola treated by a simple locally made Steffi implant with excellent results. The very challenging thing in the implant design is deformities. Can we do deformity correction with this simple implant? The answer is yes. With some examples, This is a pre and post-operative in a very complex spinal dysraphism patient. Anaconda spine in neurofibromatosis treated with pre and post-operative using locally made implants. This is a price case of a neurofibroma girl who came to us traveling 2.5 days from the Northeast with respiratory problem. And she had a very complex anterior resection and a posterior implant surgery using wires. You can see the 4 inches height gain with complete correction of the hyperkyphosis. We use this, we believe in it, and so we have used it in a patient who was affording. This is a girl from Mauritius who came and who could afford anything, but we use the same system and excellent results at long-term follow-up. This was published in international literature and the results were shown. This talk was invited at in 2009 by the annual meeting of the SRS, where we had a section on the economical options, talking about outreach to the poor. Serving the society as a physician is not only a possibility, but a sure shot success venture and a huge opportunity. And we are talking about Schweitzer, Albert Schweitzer, devoted his entire lifetime to the healthcare in rural Africa. Anyone 10 minutes. One of our motivators, Dr. Boachi from New York, Prince of Ghana, who has a great work in the social work in the field of orthopedics. And he was the president and the director of Hospital for Special Surgery in New York. And after retirement, he has settled down in Ghana and built his own hospital and is serving the poor in Africa. Coming to our local motivators, I'm talking about Dr. Abhay and Rani Bang, the Padma Shri winners who have done a landmark work in infant mortality and recently invited to address the Global Health Forum. And who is the one who's taking their work from the grassroots to the international level? She is Kazubai, a simple village health worker who was trained by the couple, and she's now devised a program for the infant mortality. And mind you, there were 12 to 13 original research articles coming from Gadchiroli, and which were published in the American Journal. Of the entire supplement on Journal of Perinatology was based on this work from the villages. So we started our rural work in Search, which is an organization which is around 2.5 hours from Nagpur. Would like to share some work, our work in Gadchiroli, the journey so far. We went to explore. Instead, we were conquered by the serenity of the place, the work culture of the place, the simplicity, and the dedication of the work there. It's a place, as you know, Gadchiroli, famous for Naxalites as well as poisonous snakes and scorpions. However, when we went there to just play a casual visit, and they came to know that we are spine surgeons, they requested us to stay behind or come often because they had spine problems there. So it was a turning point, and we were requested to go there to study the back problems. So a hardcore clinician and a full-time surgeon suddenly found himself in a challenging role of a primary care physician come researchers. It was indeed very exciting. And that's when almost around 15 years ago, we started the spine clinics in rural Gadchiroli, which is a Naxalite prone area and the tribal area. So we had to be efficient without hi-fi backup of gadgets and investigations. And there was a thorough overhaul of our clinical skills. We started doing the clinics. So we approached a double-decker approach. The first is the service front and second is the research front. We conducted a research almost around 11 years ago with Dr. V.R. Joshi's team and tried to study the prevalence, the risk factors, as you can see here, for spine problems in the neck and the lower back, the common occupational hazards in this area. We did group discussions with villagers on their views relating to the epidemiology of the back pain. We got an insight into the local remedies the villagers were following, and we started reaching out to the community. As you can see here, the tribal areas, which were almost 30-40 kilometers deep inside, where there was no accessibility, and eventually by the mobile medical units. The management protocols here were on something like a war zone surgical camps, because we followed the diagnostic triage, where we found that more than 80% belonged to group A, spine problems, which required only rehab and conservative care. 15% were with red flags requiring surgery, and 5% were complex cases which could not be dealt with there. Eventually, the clinics built up, and at any given time, we used to have 450 to 500 patients lined up for these surveys in Gadchiroli. So we started conservative care, which was needed in more than 80%, and we started interacting with the village health workers, trying to train them. We started early surgical camps around 10 years ago. This is the primitive theater, as you can see. And primitive Boyle's machine, that's my wife who started the rural anesthesia. She has a whole talk on how to give rural anesthesia in compromised situation, in prone position. Eventually, over the last 8-9 years, we have picked up work there, as you can see here. And now the state-of-art theaters are available. We do not compromise at all on the quality. Entire thing what we do here is done there. The nearest MRI, mind you, is almost 150 kilometers away in Chandrapur. And we managed to get some sort of a package where we send the tribals in an ambulance and get 4 to 5 MRIs done when the normal slots are over at night. Just to give an example of the workload, on one occasion in July 2017, we did 17 cases in one camp in just 1.5 days because we had 3 theaters and a huge team. Constrained innovation is the key. So we have to have a very active mind. As you can see here, the cost-effective diagnostic. We don't have hi-fi laser developers, so that's how we dry the X-rays. The lessons learned are find out the red flags and serious pathology in 15 and 5%, and all the remaining 80% we treat with reassurance and simple techniques. Just to give us some glimpse of the statistics, we have around 4,000 to 5,000 patients seen in the clinic so far, and almost around 250 surgical cases done so far. It's an interesting slide I would like to show you. This is Rani Bang, who herself had a spine problem, and we operated on her around 4-5 years ago in the camp along with her tribal. She had many risk factors, but she refused to come to Mumbai, and we operated on her. He is Abhay Bang, as you know, and these are his 2 kids. One is Anand Bang on the left. He is a medical professional trained in MPH in Hopkins, Baltimore, and he's come back and devoted himself to Gadchiroli. And on the right is Amrut Bang, who's an engineer who's done mass media communication, and he is running the Nirman program at Gadchiroli. So both are helping the couple in run the program. Shifting from the rural to the urban areas, as we know, in areas in in Mumbai, you can see villages inside cities, and it's a land of contrasts. How do we outreach to the urban poor? So we adopted an NGO in the Bandra East slums called as the CSSC, the Society for Study of Social Change in Bandra East slums. And we have 15 clinics. Mind you, they're not spine clinics, they're just GP clinics. And the entire work here is done through the health workers, which are housewives, which devote a couple of hours in the afternoon for healthcare. The entire Mumbai is divided into wards, and we picked up the area of H East ward because that's where the NGO was. And hence we got into VN Desai Municipal Hospital, which is in the H East ward. And it's been now 11 years since we are functioning there, where we run a free spine foundation clinic. So far, we have seen more than 20,000 spine cases in VN Desai, and the graph is just increasing. And we have now got a state-of-art operation theater, which is as good as the Breach Candy or Lilavati operation theater. We have got a good donation, and we have laminar flow and state-of-art, and we have close to around 1,000 operations till today. And we do not do any compromise. There is neuromonitoring, burr, headlights, everything, Shyam, and we do complex surgery. So all patients from the peripheral areas who cannot be done there, the 5% are shifted to Mumbai at our expense and operated here. Meticulous record keeping is the key so that we know the outcome analysis, and rehabilitation is a very important factor in spinal cases and spinal cord injury cases. So we have Dr. Gauresh Kekre, who's a rehabilitation consultant, and he has an active wing in addition to our private cases. He has an active unit in VN Desai. He's now completely involved in our rural projects, including Gadchiroli. So developing a model for comprehensive spine care is based on our experience with rural and urban on-field experience of around 20 years. So the algorithm is identifying the needy and willing areas, awareness and prevention, camps, triage, counseling and rehab, surgeries, simplistic surgeries, secondary and tertiary referrals, empowerment and hand-holding, and finally handover. So algorithm for care is no red flags, 80% only counseling, health education, prevention, red flags, try and get expert opinions, imaging, surgery at the community level. That's our difference. We try and do surgeries at the local areas, and red flags, we transfer them free of cost to centers where it can be done. This is an interesting concept called as a 5-filter concept, which we have developed and we are propagating. Filter 1 is a village health worker level, the ASHA workers, where they pick up these 80% patients. Filter 2 is the PHC medical staff unit, where we train the health workers by education. Filter 3 is the district and civil hospitals. You can see here the district and civil hospitals, the PHC doctors and the medicals are being trained in basic spine care, the basic spine anatomy, how we can pick up these 80%, which patients to refer to the specialized center. And this is propagated by media. The local newspapers and the local TV channels are used for propagation of this knowledge. This is one of the centers in, the previous was in Gadchiroli. This is one of the things in Ratnagiri civil hospitals, where we are trying to empower the local doctors, make them understand what spine care and what the spine practice is all about. Filter 4 is the established orthopedic units, and filter 5 are the urban tertiary center. In our case, the VN Desai. Scaling up efforts. Now, with this experience, we decided to reach out and spread our wings by digging deeper into the roots of our experience. So there are 3 types of outreach programs. One are the NGOs and the non-profit organizations. Second are the government, civil and district hospitals. And third are the medical colleges. So in the NGO group, we have Gadchiroli, the Search, and we have other organizations such as the Hans Foundation in Uttaranchal and Sitilingi in Tamil Nadu. In government civil hospitals at present, we have 2, Ratnagiri and Nandurbar, which are civil hospitals, but no medical colleges attached. And in the medical colleges, we have 5 rather, which are, I will go to that, Akola, Ambejogai, Dhule, Aurangabad, and now Kolhapur. A quick look at some of these. Map of Maharashtra, Ambejogai Medical College. A quick word about Ambejogai is the first medical college of rural medical college of India. But mind you, when we went there 4 years back, there was not a single spine surgery done. So when we took rounds in that hospital, there was a patient with disc and they didn't know what to do with him. And they were going to transport him to Mumbai or Pune because there was no facility for poor care. So that's when we realized the need for developing it locally. All the patients could not be brought to Mumbai. So we started a program, and Ambejogai Medical College was adopted as one of our first ones way back in 17. And now it's a very active program. And now on a routine basis, we are doing almost around 15 spine surgeries in each camp, quarterly camp. Next is Akola. You can see here the same state of affairs. Akola was slightly better. They were doing the basic surgeries. And mind you, what we do is not only sit in Akola, but we go into the local drainage areas. We have camps such as Washim, such as Daryapur. And from there, we pick up patients to get to the Akola Medical College. So there's a lot of awareness, a lot of health worker involvement. Dhule is similar, as you can see here, we started. And the advantage of the medical colleges is the takeover and the switch on or the turnkey is quick because there are interested medical students whom we can teach and they can take over. They can do the clinics while we are not there and they can help. Similarly, in Aurangabad, coming to the civil hospitals, here the problem is there is no medical college. So we have to rely on the civil surgeon and the local surgeons. But it's an interesting concept because there is no medical college. The little red tapeism is less. We can do things as we wish. As you can see here, this is the Ratnagiri the civil hospital. And again started since 17 and we have picked up very well. These are the statistics. Nandurbar is a very interesting place. It is in the middle of Madhya Pradesh, Gujarat and Maharashtra. It's a tribal area and we decided to go there because it was a completely tribal area, totally deprived. And mind you, since the last 1.5 years, we have started doing work here and it has picked up a lot. And just to give an example, We have done complex spine surgeries there in this, and including one tandem surgery for the first time ever in any rural setup. And empowering local orthopedic surgeon. There is a surgeon, Dr. Gavit, and we have empowered him, and he's now becoming a accomplished spine surgeon. So we are going there, but it's easy handover. Future projects include Gujarat, Goraj in Madhya Pradesh. We are looking at Chhattisgarh, Indore, nearby Indore, Jharkhand. We already started tied up with the Ranchi Medical College, and Dr. Nishant, who's part of our team, is looking after it. Tamil Nadu, this is a very interesting thing. We have adopted a tribal health initiative in Tamil Nadu. It is in the middle of nowhere in the valley, and there is an excellent couple there, Regi, George, and very good setup, and that's where we have started in Tamil Nadu. You won't imagine that in the interior of Himalayas, in the Pahadi areas, there is no medical care. And we have decided to reach out to them. And we had started off with Rishikesh, then Dehradun, and now we are going to the Hans Foundation, which is in Satpuli, which is like 6 hours drive from in Himalayas from Dehradun. So lessons learned are scaling up these models all over the country is what we are looking at. What is very important, I would like to mention, is we are setting up a national center for comprehensive spine and musculoskeletal care for rural care in Gadchiroli. This will be first of its kind. And in addition to the 11 centers where we are reaching out in Maharashtra and India, we plan to set up a teaching center in Gadchiroli, which is a national teaching rural center, where in addition to the local care, we'll be inviting people who want to do something. Like for Orissa, we can't keep on going everywhere. Someone in Orissa who wants to go there will come, we'll train them, and then we'll send a team out for them to start something there. So this is what we are trying to do, and it's in the process. In a year or two, we'll have the center set. Critically evaluating the outcomes is very important, trying to identify the deciding factors, trying to compare the costs of the comprehensive care. Setting up hands-on training modules is what we are looking at, developing exact protocols and algorithms which everyone can follow, developing the system of 5 filters which I explained to you, and we are fine-tuning the pore size of these filters so that less and less patients come to bigger centers and more are taken care of peripherally. What is very important is see, the government has provisions, the government is providing money. So we have to get that into the mainstream. So we are trying to get these government schemes, Rajiv Gandhi and Jyotiba Phule schemes, the national policy and the various schemes which are available into the foundation program so that we give the expertise and use the money which is provided. Introspection and relevance is what all we learn today of any help to the person on the road. So I think we have to think global, but we still have to act locally. Constrained innovation is the key. This is a very important book which I would strongly recommend for all of you to read. It's called Fortune at the Bottom of the Pyramid. And we don't have time to discuss it, but I would strongly recommend you to read the book. What it says is, the very poor at the bottom of the pyramid need to be serviced. And if you concentrate on numbers, you will be able to soon convert the pyramid into a rhomboid. And we'll have more of middle class rather than more of the poor. And the whole aim is of converting the pyramid to a diamond. The last few slides are on very interesting concept. These are 2 Indians, Govindarajan and Ramamurthy, who are based in the US, and they are in the business category and the Harvard Business School, and they are in the University of Boston, and they have written this book called Reverse Innovation in Healthcare. And what is it about? They are talking about a concept which is akin to what we are trying to do in Spine Foundation. Poor countries no longer just rob innovations from developed countries. They also contribute innovation to the rest of the world, including the developed countries. We call this transfer of new ideas and innovations from poor regions to the rich as reverse innovation. So that's what we are looking at. And they have highlighted the difference between the healthcare of India and the affluent areas such as United States, and how United States now needs to look at our. And that's where the Spine Foundation becomes very important. The president and CEO of the Cleveland Clinic, Toby Cosgrove, mentioned that the ideas in reverse innovation in healthcare could save American healthcare billions of dollars. Robert Kaplan, who's the Marvin Bower professor from Harvard Business School, has mentioned that the reverse innovation in healthcare definitely delivers on its mission to show how to make value-based healthcare. We had a look at the examples they had quoted and realized that our model of spine foundation was completely unique, because all the examples they have quoted are basically the providers are looking at earning money and cross subsidy, whereas ours was a complete non-profit where we are actually paying for the cost. We are not earning money at any point, as against all the others. And we are also, the very important difference between all is they develop centers and they get the patients to their centers. Whereas in our centers, we reach out. Even the complex care such as spine care is delivered in the periphery, in the remote areas, as remote as Gadchiroli. So we are trying to offset the cost by relying on funding of the government agencies, and we are trying to tap the CSR component of corporates. This excellent book on Operation Health, which mentions about the surgery in primary healthcare, has multiple chapters, but not a single chapter on spine care. And we are trying to approach them to share our experience at the foundation so that we get a chapter and people are aware that spine surgery can be done as a primary care peripherally. I would like to invite interested public health and global surgery students, interns, MPH and PhD to study our story and its varied aspects for its projects and PhD program. So I would like to invite you to come along with us today, tomorrow, and whenever you are ready. Join us in this great journey. We are eagerly looking forward to constructive criticism and ideas to enhance and to dream with us. If you have any more ideas, you could get in touch with us on this email, or you can WhatsApp or SMS on this number. Thanks for being with us and giving us this opportunity to share our excellent journey and to share our future dreams. They are all waiting for us to deliver. Thank you. A big thank you from the Spine Foundation.
What an absolutely delightful half an hour it's been. We are living the modern dream with a modern saint, and these are the people who actually contribute towards the country getting up to another level of services, and the entire show runs on being selfless and contributing where it really matters. So that was a fantastic talk. If this doesn't motivate you, I don't think anything else will. And we've got some great panelists here, right, from Dr. Ganjwala to Dr. Raghuprasad Varma, Dr. Satyen Mehta, of course, Dr. Neeraj Bijlani, Dr. Ashok Shyam, Dr. Premik Nagad, and of course, Dr. Priyank Patel. So I'm going to hand over to them to do some Q&A and some brainstorming over, some of the obvious questions. Maybe we'll hand over to Dr. Raghu Varma for the first question.
Thanks, Abhay. Thank you, sir, for that motivational talk. One thing that crossed my mind when I heard this, that your few initial slides looked at the need in the community, and the next few slides looked at the motivators which actually led you to conceiving the idea. But our question as a simple layman would be, when did you decide that the community needs spine care? At what stage in your career? Because you're such a busy practitioner. What stage did you feel like involving or incorporating that aspect in your
I think I would it's a very interesting question. I would like to give credit to two people. I think my family background, because I come sort of from a Gandhian background, and my grandfather was a freedom fighter, and all along as I grew up, in addition to they being doctors, I was all the time hearing about the social aspect, the need to give back to the society, the Gandhian principles, the role of remaining at the grassroots level. So I think I would give a lot of credit to that. I grew up in that atmosphere. And the second was my stint at the KEM hospital. I think whatever I am today, I would give maximum credit to my stint at the KEM hospital, because I have, after being a student of KEM, I never left campus. And I spent almost 18 years in KEM hospital campus. And there I was like neck deep. And the first spine unit of the country, so to say, was initiated way back at the KEM hospital, dedicated spine unit. And I was involved in the patient care of people who were like have-nots. People from all over the country came to KEM and the spine care. So suddenly when I entered practice, there was a huge vacuum, and I had to fill that vacuum, and I was very restless in the initial years. And that's what brought, so I knew there was a need because I was in with those people with the need all along. And then suddenly I came into the private world. So that's where I worked on. And the next couple of years after starting practice, the Spine Foundation took birth.
Sir, I had a question for you. We saw that your dream was to get set up RSCC centers all around the country. So do you feel that this dream is really scalable? And I'm sure a lot of roadblocks must have had your way. So which one of them were the most difficult to cross?
See, whenever a busy doctor from a metro tries to get into public health, I mean, people are a little worried. I mean, what's going on? Why does he want? Do they do this? Do they want to increase their practice by attracting all sorts of things? To get into VN Desai, I had to spend almost 4 years running from pillar to post, and they couldn't find a reason why I wanted to get into VN Desai. So similarly, when we went to the rural areas, especially the government medical colleges, there was a big resistance because they were happy with what was going on. They didn't want a change, and things were going on at their own pace. Ambe Jogai, for example, they were happy not doing a spine case since the inception of the hospital, which was the first rural center. So there was a huge resistance in the urban as well as the rural spine foundation centers, because you are trying to go against the flow, trying to make a change. So besides they wanting to know why I'm doing this, there was resistance. I mean, no one wants to work extra, but once the clue is to stick to your guns and try to show, and eventually the people who are interested, once they know that the people are getting benefited and there's a huge change occurring, and the medical college, Ambe Jogai, for example, which did not have spine care, suddenly being recognized as a spine care center and people being referred from all over. At one point, we had some 900 patients coming from all over in Ambe Jogai camp. We had to refuse around 200 patients because on the ST stand, the rickshawalas, they were all posters, and there was a huge mela. So basically, you have to be ready to face the initial roadblocks. But if you have to stick to it and if you believe in what you're trying to do, that the need is real and you want to not let go, then things turn. And even VN Desai, after initial resistance, now, I mean, all the management people, their relatives, everyone, it's become a very important urban referral center. So roadblocks are always there. But once you realize that you have a mission and there is a need, you can always overcome that. You have to be persistent, perseverant.
Correct, sir. Thank you.
So there is a question which comes into everyone's mind in this materialistic world of today. Does ego come in the way of social work?
What comes? Sorry, I didn't get it.
Does ego come in the way of social work in this material?
Ego?
Yes, sir.
Not really. I think once you decide to do social work, that itself means you have to dissolve your ego, because it's a thankless job in a way, because you're being insulted right from day one and you have to be ready for it. Basically, your aim is to serve someone, to serve the population. So anything which comes in between, you have to just accept it and swallow. So if you may be insulted by a ward boy or you may be insulted by they don't know who you are, because your ego is functional in cities where people know you. But once you go to Dhule or Nandurbar, you are as good or as bad as a local GP or a local homeopath. So ego is totally to be kept home or ideally dissolved. So I think once you decide to get into social work, ego is not an issue. I mean, people with ego normally don't get into this mess.
Thank you, sir. That was a really fantastic answer.
Dr. Satyen, do you have a question for sir?
Yeah. Sir, your concept of urban poor was very interesting. Whenever we talk about social service, we talk about maybe going to the rural areas, villages, but you brought about the entire concept on urban poor who need your help. Can you elaborate on that?
Yeah, we realized actually what happened was after we started doing Gadchiroli, when we came back, we used to do Gadchiroli visit once in 3 months. And then suddenly we were so much used to serving the needy. And once we came back, you were again in Breach Candy and Lilavati, and we knew the need was very much there. And we realized, as you know, once you step out of your house, you will see slums, you will see rickshaw fellows, you will see people on the road. And being part of the spine unit in KEM for 18 years, we knew really that the need is. And I would say that the need of the urban poor is a little more different and more pathetic, because they see in a village, in a tribal, he doesn't know what's available. So he's happy with what's going on. In Bombay, he knows that there is breach candy, he knows there are 5-star hospitals, but he can't approach. So they are they are in a way more needy. So I think that need was real. We realized it. And good work was anyway being done in major hospitals. As you know, KEM, they have very good units and work, but the work was so much. The H East population, we did a survey, the H East population itself is 13.5 lakhs. Just imagine the population around VN Desai is 13.5 lakhs. We have done this survey. So just that population, you could have how much spine problems and all this. So if you come and attend one of the last OPD we had on VN Desai on a Saturday, we had 55 spine cases and almost 20 needed workup for surgery. So that's the real need. Plus, once we have all these 11 centers from all over, a patient in Ratnagiri, for example, who needs to have a scoliosis correction, we cannot do it in Ratnagiri, as at least now we can't do it. Maybe eventually we'll be able to. Now Akola we are doing scoliosis because we have a medical college, but Ratnagiri is a civil hospital. So where do these patients go? So we get them to Mumbai at our cost, along with the relative, house them in VN Desai, put them on the scheme and put them through the foundation. So VN Desai has become a very good way of servicing the peripheral hospital referrals as well as the local population. So I think it's a very important concept. And I feel anyone who enters practice must have one leg in a civil hospital, because that's where the real need is. That's where there's a lot of work. Otherwise, you're just sitting in a very big corporate hospital doing nothing much.
So just to enlighten those who missed out, VN Desai is one of the large municipal hospitals in Bombay, which services a very huge area. And it's a standalone hospital which has very meager facilities. And Dr. Bhojraj with the Spine Foundation came in and set up a huge state-of-the-art operating theatre there. And today, there's free spine surgery offered to the poor patients of Bombay in the heart of the city in Santa Cruz. And very few people know about it, but it's churning out more and more grateful patients. Dr. Satyen.
Yeah, so there's a question from my co-host, Dr. Dhiren Ganjwala. So he wants to know about how you are able to find talent to go and work with you in these remote areas. It's not possible to do anything alone. You need a team with you. So how are you able to attract?
As I mentioned, I didn't have enough time because I could talk just on this concept. So we have what is called as SSFG Fellowship, which is Spine Foundation Fellowship Group, which is an ever-increasing group. And at any given time, we have 3 spine fellows, and which has a 2-year commitment. So they have a 8-month rotation of 3. So 8 into 3, 24, so 2 years. And out of this 2 years, 8 months they spend in VN Desai. So where they get an exposure to the approach towards a poor patient. We have an OPD which they run. We have an red card OPD, and they realize that we are giving. And they also work in Bridge Candy, Lilavati, Khar, Hinduja, everywhere Hinduja. Say they know that there is no differentiation between that care. So it's basically sensitization of the philosophy of this uncompromised quality care to the poor people. That is one aspect. And second is, in the earlier other 8-month rotations, they are taken with us for these camps. So they come with us, they stay with us, they stay in villages along with us. So they basically, by the time they are finished, in addition to being trained in surgical techniques, in hi-fi things like robotics, O-arm and everything, microendoscopy, everything, because they are spending time in the city. They are also, as a parallel training, being sensitized to urban as well as rural poor. Here there's a very important point that in selection of these fellows, it's a very important thing that out of the 3 fellows, we make it a point to select at least 2 fellows who are not from Mumbai or big metros. Like for example, right now, to give an example, we have 3 fellows. One is from interior MP, one is from Bid district, and one is from Uttaranchal, Dehradun. So what are we trying to do? Because at the end of 2 years, they are all post MS or post DNB. At the end of 2 years, we'll have 3 spine surgeons who are going to be sensitized, who are going to know the latest things, so they can go back. So we have a potential spine center coming up in Bid, potential spine center coming up in interior MP and in Uttaranchal in the Himalayas. So then there are links. So we have now an ever increasing. So each year we have 3 fellows coming in. So now we have a group of almost 40, Abhay being our first fellow. And we have a now over expanding group of SSFG group. And that's the criteria. So for example, just to give an example, the Ranchi Medical College is taken over by Nishant, who was a fellow. And mind you, they don't go only in the villages. Like Nishant was trained in Singapore and he's trained in everything. So when he goes back, he has his corporate attachment, private practice, but he is committed to Ranchi Medical College. He's committed to, he'll come for a camp in Gadchiroli. They can sign up because we have 40 people. So there is actually a wait list. We have Tushar Devre, who's a top consultant in Jupiter Hospital in Pune. But he signed up for Nandurbar, Dhule, and now even Kolhapur. So he devotes his weekends. So that's how the whole thing works, and it's working out very well. So we are never short of hands, and this is a special emphasis we put on the training.
Sir, I've got a question for you. Costs are always a big concern for all these projects. So how do you manage to arrange for funds for all these activities?
It's a very interesting question, but there are 2 aspects of this. First, there is, Dr. Abhay always says that when you have some good intention, good work, money is never a problem. And initially I thought, I don't know what he was talking about, but I believed in it. And you have to believe me when I say that no project of Spine Foundation was stopped because of lack of funds, which is a big thing. I mean, I don't know how it works, but once you show good work, like VN Desai, we didn't have to go with a begging bowl. Once people knew, there's a donor who came across and just gave 500 crore and did the VN Desai OT. We didn't have to approach anything. So number 1 is doing good work and showing that you're doing good work by outcome analysis, and you'll get people donating. So we normally get these donations from philanthropists, doctors whom we operate, whom we don't charge, and then the CSR of companies. So there's an active marketing going on, but this is a concept. And second most important thing is we try to link our projects with government schemes so that our expertise is important, but we don't need the money so much. Or we directly link the donor with a project. Like we had a big donor which we linked with Nandurbar project. So we are not at all involved in the money part. That person completely equipped the Nandurbar operation theatre. So we have a state of operation theatre in civil hospital in Nandurbar, where we are not involved in any money and the recurring costs are done there. So to answer your question, 1 is we need money. So donations, CSR, number 2, linking government schemes and the CSR. And finally, just do good work and you'll have donors floating. We have so many times people approaching and asking. So now we have stopped collecting, but what we are doing is linking them directly. We give them the project running cost and they're very happy. For example, Alchem is taken over the Gadchiroli project. Mr. Dalal has taken over VN Desai and Gadchiroli. So there are donors. Sitilingi is taken over completely by a donor. So we provide the know-how, the technical support, but the money comes directly from the donor to the project.
So what is amazing to reinforce here is that the Spine Foundation is probably one of the only NGOs in the world where there is zero administrative expenses. All the money that is donated is directly given to the recipient. And strangely and amazingly, all the administrative expenses are borne by one individual. And that's the guy who just spoke to you for the last half an hour. So it's something that comes straight from the heart, I would say, isn't it? Dr. Raghu, you're muted.
There's one more question I want to put across before we wind up.
Raghu is our present president of the Spine Foundation. So let me introduce him officially.
Thank you, sir. No, so if I could ask you a question, lack of time is one of the things most of us as professionals complained about when we don't have time for social obligations. Now we know you, but for the benefit of the others, you're somebody who does a lot of sketch work, painting. You've got time enough for cycling. With all of us, we can sometimes shame all of us the way you cycle. You've been running earlier. With all this busy practice, professional and personal commitments, how do you find time? Because that's something which all of us would now want to.
I think it's all about priority. And what I have realized as I aged, so to say, is that you can't wait for these things because it's a need of the hour. You can't say that, let me retire and then I'll do social work, because you're losing out time. So you have to find time to do these things. So just to give an example of a working week, like Monday morning to Thursday night, we are completely in private practice. And Thursday night, we normally board a train which reaches one of the centers. So Friday and Saturday, we are working there, either a pickup camp or ASHA worker camp or a surgery in the rural area. And Saturday night or Sunday morning, we travel. So we are back in Mumbai on Sunday. So that's like a typical timetable which is there. So you cannot say that once I retire, then my whole life I'll give, because by that time, you lost the bus, you missed the bus, you lost the initiative. It has to go on side by side. So you have to find prime time to do these things, because see, as you saw and as I explained, it complements your private practice, because all you learn from your private practice, the tips and tricks you're going to use to upgrade your product. It's not that upgrade your product in a rural area. So have a reverse innovation. You can actually change things in the urban setting. What you learn from urban setting, you can apply there. Just to give an example, is a telemedicine. The COVID has taught us that telemedicine is such a big help. So what we are trying to do, we used to have pickup camps in, say, Gadchiroli. So the whole team used to fly down to Nagpur, go by bus to Gadchiroli, spend 2 days. So basically 4 days, consultants used to be in Gadchiroli, travel cost, everything. Just last week, we did an online peripheral pickup OPD in Gadchiroli, in the tribal area. And it was a huge success. So this is a learning experience. So an online OPD in an urban area, which we did for our private patient, we got the clue, we learned from it, and we practiced it. And just last week on a Friday, to be precise, Friday 2 to 4, we were in Gadchiroli, sitting in our office in Mumbai. And we picked up 5 patients with red flags. And this Friday, we are going to see their pictures and follow up. We picked up one avascular necrosis of the hip, which was sent to us, a tribal, which was sent to us for a sciatica, to actually all this online. So this is all, you cannot wait. So time management, I think, is real time. The need is now. So don't wait. If you want to do it, just do it now. Find time. There is enough time for people who want to do it.
So technology reaching the masses in the truest sense. And it's been really enthralling. Dr. Premik, one final question from you.
Okay, sir, this question is a little, so much of social work being done by Spine Foundation all over India. Do you have any particular memorable story you can share with us for the foundation?
Each patient in Spine Foundation treatment is a story. You can, if you want, you can come to VN Desai and just sit with any patient. It's a wonderful story. There's a patient who has come from UP. He went to Lucknow. He got operated there. Then he had an implant exposure. Then he came by train to Mumbai. Someone told him about VN Desai. He took a rickshaw, came there. He got sorted out, went back. And he comes for follow-up once in 6 months, all the way from UP. I mean, each one is a story. Just to name a couple of things, there was... Actually, I showed you a picture of a tribal lady. We went on one of our camp, lady, short 4 feet, was bedridden. And we found out she had actually a chronic cauda equina type of syndrome. And she was claudicating, she couldn't reach the toilet. And so we just picked her up and sent her, got an MRI done. And today she has mild weakness, but she's recovered most of it. She's walking around. Actually, the picture which I showed you with Ranitai was one of our follow-up visits. They cannot come to the hospital. Some follow-up visits, we have to go and visit them in the tribal villages. So that was one area, one thing I can think of. Second was a patient we picked up. This is a success story of rehab. Patient we picked up from one of our Ratnagiri camps who was in bed for I think 1.5 years with bed sores. A young boy had fallen from a tree in Ratnagiri, Kokand, and fractured spine and zero rehabilitation with stiff. So we just got him with his relative to VN Desai and worked on him for almost 1.5, 2 months. Gauresh did a great job. His picture also was in one of the slides. And today with calipers, he's walking and he's on a wheelchair. He's employed in Ratnagiri. So, I mean, there are multiple stories and we can go on and on. I don't know whether we have time. Another thing which has excited us is Sitilingi. Sitilingi is in the middle of nowhere, in the middle of Tamil Nadu and Karnataka and in the deep valleys or jungles of Tamil Nadu, a tribal area. And they have never, language is a big problem. Luckily, as I told you, we had a fellow and he speaks Tamil and we selected him. He was trained in Satyen with Dr. Rathod, but we selected him for fellowship because he was going to go back to interior Tamil Nadu. And now he conducts a camp in Sitilingi and we go there for surgeries. And it's amazing to see a tribal area who has no access to healthcare having access to spine care. I mean, that's so rewarding and so satisfying. So we can sit there once talking about all these stories.
One final question from the boss of OrthoTV, Dr. Ashok Shyam.
Thanks very much, sir. It was an amazing 1-hour session, and thanks to you from bottom of my heart for doing this with us. I have a question of the project. Such long-running project require constant reinforcement or constant drive. We have to feel that it is worthwhile, and what we feel worthwhile is very personal to all of us. So I wanted to know from you, what do you feel is one of the most worthwhile points for this Spine Foundation project, according to you?
I think it's the installation of that spirit in your new fellow who comes under your wings for the training, because that's your value. Because the moment you stop sort of stimulating your fellows into social work and keeping that private angle, you can't tell them that you go and one person stay in village. He has to have his life. You have your life. He is going to have life, but he has to have an awareness. Zaniu, we call in Marathi Zaniu. He has to have an awareness of this social angle. And I tell you, each one has the human thing. It just has to be ignited. And once that happens, it's very easy. Actually, they take it forward for you. You don't need to do much. And you have to live by example. They see you. It's not that you are sitting in an AC office and advising them to go. You have to go with them. You have to work. You have to show them what it is all about. And luckily, we have these 6-7 trustees in foundation who have sort of lived the life, and each one has instilled it. Once you enroll a fellow, I think that's the main thing, because someone who's not interested, and that is one of the important things we judge when we select a fellow, how keen he is to go back and give back to the society. And that's a very big plus point. And so I think that's the thing, because this is something you cannot artificially, or you cannot inculcate. It has to be inbuilt, and I feel each person has it. It's only an opportunity or exposure to the right surrounding that you get to know it. So I think that's very important.
Such words of wisdom. India is a land of contrasts. We have the top class healthcare available in the cities, but 80% of India lives in rural centers where there is absolutely no healthcare. And the Spine Foundation has been weaving a bridge from urban healthcare into rural India, where it really matters, for the last 30 years. There's one man who's changed this from an idea to something that's out there, and we just heard words of wisdom from him. This is the dream we all need to live. We all need to get into the shoes, line up, and just shut your eyes and follow the guru, and you go on the right track, rest assured. This was an absolutely enriching and rewarding motivational Monday, And many thanks, Dr. Bhojraj, from all of us and from the entire audience that's been watching you. There have been messages pouring in and there's been stuff that's going on the YouTube. Thank you so much, audience, for sticking with us, because it's for you that such talks come out in the open. And of course, thank you so much, OrthoTV, Dr. Neeraj Bijlani, Dr. Ashok, Shyam, and may you continue to motivate us Monday after Monday. Wishing you everyone a fantastic 2021 and salute Spine Foundation and Dr. Bhojraj. And with that, we'll call it a night today. Cheers.
Thank you.